And now, dear Torsten, so I have now my patient in front of me, and I have now to decide whether I send it to Rima, to the Netherlands, or whether I should send it to you for exactly the investigation of the same vascular branch. And now I think you need to convince me that I send the patient to you, or maybe also say that I should send the patient to both of you and do the combination of both imaging techniques, or actually 3 types of imaging. So the question is, Torsten Bley from Germany, radiologist, large experience in the field of MRI, and did a lot of studies on MRI of the cranial arteries, and now he will respond to the question, why should I use MRI or CT for diagnosis and monitoring of large vessel vasculitis?
Well, thank you, Christian. Perfect. So thank you very much for having me discuss with you the question, why should I use MRI or CT for diagnosis of monitoring of LVV? These are my disclosures. And let's start with the reasons for MR here. With a very high resolution, we can zoom in to the superficial temporal, or this parietal branch of the temporal artery. You can see the superficial parietal branch of the temporal artery with the circular enhancement, and the black hole in the middle is the flow void, so no signal in the high flowing artery, and there's the vein with no flow void with a clear white lumen. And due to the high resolution, you can visualize these findings. And our criteria in MR are for enhancing and inflamed arteries are 600 micrometers in thickness, measured like this, and concentric enhancement. And on the very first view, you can see which segment is involved and which is not, even without enlargement. These little boxes are enlargements of those, and well, a little bit indicative here, the red. This is the inflamed superficial left frontal artery. This is the inflamed superficial occipital artery on the left side. And on the right side, you can see this is just vasovasorum. There's no inflammation. So on the first glance, you know which segment is inflamed and which is not. And I want to show you one old case from 2005, because that was a game changer. From this time, our rheumatologist started loving MR, because this patient was an outpatient who received a large artery segment being harvested, and that was negative. His clinical suspicion, there was giant cell arteritis, but the biopsy was negative. On the left side, you can see there is no enhancement. The wall is barely seen. This is our fiducial marker to know where we look at this early times. But even without enlargement, and even more so in the enlargement, you can see superficial occipital arteries are inflamed. And I've seen several cases where only the occipital superficial arteries were inflamed and not the frontal and parietal branch of the temporal arteries. So I suppose, and it's not proven, but I'm very convinced that taking a biopsy out of this segment would be negative as well. Anyhow, so this is reason number 2. MRI displays cranial distribution pattern. Reason number 1 was MRI displays the superficial cranial arteries. Now let's look at the large vessels. And there's a large study from France with 248 patients that had large vessel involvement initially, and 301 patients with GCA who did not present with large vessel involvement initially. And those patients with large vessel involvement were younger, had less cranial, but more extracranial vascular symptoms. And they developed in 21% aortic dilatation as compared to those who did not have large vessel involvement initially. And you can see that after about 2 years, the two groups separate. So the one with initial large vessel involvement had a higher risk of aortic dilatation, and there was a hazard ratio of 3.16 in this study. And a Scandinavian study supports this finding, and they found that it took about 3.7 years in the median for developing aortic dilatation. So reason number 3, large vessel vasculitis assessment is possible even without radiation. And if you look at this graph that shows different clusters of Takayasu and giant cell arteritis patients, and we want to focus maybe on the Takayasu, on the giant cell arteritis group, 83.8% had this distribution pattern. You can see what we have discussed earlier this afternoon. It's the aorta and the supraaortic branches that are very oftentimes involved. And MR as PET or CT can give large volume coverage or even time resolved information, and you can see the collateral vessels, as in this patient with a Takayasu's arteritis, and you can reveal the occlusions and multiple stenoses of the supraaortic arteries. So reason number 3, large vessel wall enhancement and stenosis can be assessed even without radiation. Now, I do not recommend to have whole body imaging in all patients, but what we do in our institution in Würzburg is we performed a combined MRI protocol that is combined with the angiography of the thoracic aorta and the supraaortic arteries. And that takes about 30 minutes. And you can readily reveal inflammation of, in this case, the left and the right superficial frontal artery and the occipital artery. So this is one of those cases Bhaskar already mentioned, that many arteries are inflamed at once. So in this case, it would not, certainly in our case, not use a biopsy to confirm the diagnosis. But if biopsy was performed, I'm very convinced that both sides would render positive findings. Now, this is combined with the angiography, and you can see it's also marked with the arrows, the occlusion and stenosis of the right vertebral arteries. So that's all in one package. And afterwards, we have high resolution transversal imaging, and you can see the enhancing inflammation of the right vertebral artery, which is somewhere around here depicted in this little picture. And if you are interested and focus on the intracranial arteries, and there's different findings in literature, but I'm convinced that there is intracranial vasculitis in giant cell arteritis patients, as in this particular one. On the right side, the intradural right carotid artery shows the same signs of inflammation that we have seen and biopsy proven in the extracranial arteries. And on the left side, it's normal. Or this is a different coronal perspective. You can see the circumferential thickening and enhancement of the intradural right carotid artery as compared to the left. So it is even possible to look inside the intracranial artery vessel walls. So that's reason number 5. Manifestation. However, that is not combined in our routine protocol in this 30 minutes I was just discussing a minute ago. But there are challenges or obstacles. And I want to quote this study from ARD 2018 that compared or revealed positive imaging findings despite clinical and laboratory remission. As for example, in this particular lady, she was in clinical remission and still revealed MRI signs, stenosis persisted, and signs of inflammation despite her clinical remission. And by the way, PET had the same difficulties. And in this study, there was no clear delineation of clinically active and remission patients as confirmed by MR or PET findings. So that truly is challenge number 1, and that's the hardest obstacle to overcome in follow-up imaging with, I believe, all imaging studies, but I want to refer on CT and MR in this presentation. Now, this is my second last slide, and I want to quote this recent study from the University of Bern, and they had a really, and you probably are very well aware of this study, they had a strong regimen of only 3 applications of methylprednisolone, and then they stopped it completely and went on with tocilizumab at day 3 and then for 52 weeks. And what I draw your attention to is this graph here. The intima media thickness, as measured by ultrasound, decreased rapidly during those 3 days of steroid treatment. And then when steroid treatment was stopped, which is about here, the IMT increased again, and then slowly tapered during the long-term treatment of tocilizumab. So this is what we have seen in the earlier days, where only giant cell arteritis was treated by, GCA was treated only by steroids, and we saw the rapid decline of the mural findings in all imaging modalities that we were using and in MR as well. So these are the reasons why I propose MRI and CT for the large arteries. MRI depicts the superficial temporal artery inflammation and the cranial distribution pattern at once. It can be combined with an MR angiography of the head, neck, and thorax within 30 minutes, and all this without any radiation application. Now, if you use CT, of course, you do have radiation, but we do not see inflammation of the superficial temporal arteries with CT so far. MRI may be used to reveal intracranial manifestations and does have severe challenges, like other imaging techniques as well, to depict mural changes despite clinical remission in the follow-up, and it may not be as widely available. Thank you very much for your attention, and this is for discussion.
Thank you, Thorsten. Thank you very much for this nice presentation. I really have a burning question and a very practical one. So the waiting times, at least in my place, they are like 6 to 8 weeks for an MRI. And so how can I convince, or no, I must reformulate my question. How have you organized it in your institution that you can have a fast track MRI?
Yes, that's a very good question, a good point. And I believe that what you experience, many of the audience will also experience the same. First of all, that's a killer. If you wait 6 weeks for imaging, you can also, I don't know, you don't.
From a biopsy.
Yes. So proceed with imaging as fast as possible. How do I organize this? Well, in my situation, but even before I took charge of all MR scanners here, in my other university experience, I was just interested in imaging, and I made it possible by one-on-one interaction with the rheumatologist. But if you go on regular scheduling, that will be tough, because MRI service is so requested so often, so we are overwhelmed by our referring physicians. It's hard to squeeze in. So you need one-on-one interaction and interest of the radiologist to get it in. And your question was, how is it performed in Würzburg? Well, every patient, no matter where he or she will arrive, it could be neurology, ophthalmology, and rheumatology, they all will receive ultrasound and the MR combination study, and we try to do this within 24 hours. It's maybe not possible on the weekends, but if a patient arrives, let's say on Friday afternoon, she or he will receive MR and ultrasound within Monday.
Probably at midnight or something like that, so that you add some additional slots in the night. That's
no.
For the residents, they really will love it. So when they have some night shifts because of the MRI, but probably that's the only way how you can organize it.
No, actually, I do it in the early mornings. It's prior to the start. So we start at 8 o'clock with scanning, and sometimes patients are not in time. And if I order a patient at 7:30, there's always enough time to get it done prior to the routine.
Okay, that's great. Christina had a question.
Yeah, so I was wondering, you said, actually 2 questions but related. You said that the occipital arteries you've seen several times, they have inflammation, but not on the temporal arteries. First, my question would be, do you have any idea of the percentage? Like, for instance, in ultrasound, we don't have that much of a perception, maybe because our probes are not so good and it's extensive areas with tortuosity. So I would just like to know more or less the percentage. And also, those patients who have occipital artery involvement without temporal artery, but you actually ended up performing a CT or an MRI to the thorax, do you see other arteries like axillary or subclavian, or what, just to understand the isolated occipital inflammation?
Yeah, that's a very good question, Christina. So first of all, it's rare. I could recall out of my head maybe 4 or 5 patients. So it's in a very small number. In the majority of patients, it's multiple artery territories inflamed. Multiple meaning at least 4 of those 6 cranial arteries we were looking at, and in some of which it's all 6. So in most of the patients, it's a systemic disease. It's multiple artery segments inflamed. And only in rare cases, and as I said, 3 or 4, but just recently we met in Norway, and the next week I had one again with only occipital. So it does happen in rare cases. And the second question, I will have to dig in and look at it. I do not know in those rare cases where they have large vessel involvement as well. I simply do not know.
Maybe. Thank you.
Okay, Wolfgang?
Yeah, I think we still have quite a lot of open questions for follow-up. How do we pick up those patients who may die from aortic aneurysm or get a rupture or dissection or something like that? So how often do you see aortic aneurysm in the descending aorta without involvement of the aortic arch and the ascending aorta? Because it takes a couple of seconds actually if you have an echocardiography probe to look at the first 8 centimeters. And I feel, but it's just a feeling and not knowledge, that we get quite a lot of patients who have over 38 millimeters in the aortic arch and now in the ascending aorta, and maybe the aortic arch we can also see. But are we missing patients who would perhaps die? What's your impression if you look at your experience for MRIs for follow-up in order to find aortic aneurysms?
Now, Wolfgang, those were 3 very important questions. First of all, evidence is lacking. We do not know. We have to build evidence and we have to do studies in order to find out. I guess we do not miss many patients, and we know it takes time to develop. It is not a one to next year development. It takes years, and then patients are old and may have concomitant other morbidities. So that's a different question and to answer. But in order to do so, we and others, I already know, perform regularly follow-up studies in all patients to build up evidence. In our situation, it's after 6 months, after 12 months, and then regularly every year, and in a relapsing disease. And then they get the same package again: ultrasound, MRI, and we have started with PET as well in those cases where uncertainties arose. So PET is a wonderful tool to clarify uncertainties in initial diagnosis, uncertainties in remission and relapsing, because I believe it's the most sensitive tool.
And how many aneurysms do you see that are exclusively in the thoracic descending aorta? That would not involve the aortic arch and the ascending aorta. I know it's a difficult question, which I don't know. I don't know the answer. So I don't know if you know the answer.
We need to.
Another question which interests me.
Yeah, no, this needs to be evaluated. I do not know. We don't have the numbers yet. But I believe it will be a rare case scenario.
Actually, I think that we are in clinical practice. In reality, we do not see so many patients that either die or need surgery from a giant cell caused aortic aneurysm. So I think probably, but that's a bit my suspicion that that's a bit overestimated in the literature. So we have done an analysis of the cases from Graz, and that has been published last year. And there were very few, actually, I think only 1 or 2 patients which really needed surgery from aortic aneurysms out of a cohort and more than 150 or so. And so I'm really curious to see this data.
Yes, but
sorry, go ahead.
That's true. I also believe it's a small group of patients, but disease is severe. So the reaction, aortic surgery in the elderly patients is severe. But even if we detected increased diameter of the aorta and then aortic aneurysm involvement, we do not know. I guess you may be the first who have to come up with a treatment decisions. Now, are you going to increase your anti-inflammatory therapies? There are no guidelines yet, as far as I know. So how to react on those findings will be the next question. But there's a lot.
Well, absolutely. So my feeling is, so I think that it's also still open that in a later phase of the disease, whether then really the inflammation causes the dilatation of the aorta. So, you know, in spondyloarthritis, we have the inflammation at the beginning, and then we have the transformation into the fat, and the inflammation is gone, and then come the syndesmophytes. And so probably in GCA, it's similar, that we first have the hit, which is the inflammation, and then we have a phase of remodeling where the inflammation is gone, but still the impact would be positive because it's still glucose consuming, and maybe also in MRI we would see a signal, also because there is neovascularization, and probably the formation of the aneurysm is more linked to the remodeling and the reorganization of the aortic wall, and not so much anymore to the inflammation. I don't know how the others see it, but I think that could come out.
And if that is the case, it would be, in my opinion, valuable to know which patient is persistently showing those inflammatory or revascularization findings, because you can then predict there's aneurysm likely to come.
Yeah, I think one hint to that is that the majority of dilatations occur when patients are in perfect remission, so years after an initial diagnosis. And that's probably, so yeah, it could be smoldering subclinical inflammation, but it could equally well be that inflammation does not play any more a role, and it's remodeling and the restructuring of the aortic wall that makes it weaker, and so it dilates. And I don't know what the others think, Wolfgang and Christina. Do you have other thoughts, or would you?
Christian, if I can say something about this, because we are following up our patients by using ultrasound, and all the patients also that are in remission, we have a protocol and perform ultrasound of the ascending aorta and the aortic arch and the abdominal aorta every year, yearly. So at the diagnosis, we discover some patients have it somehow more than 35-40 millimeter in the aorta, in the ascending aorta, and those patients we categorize as not aneurysmatic, but somehow in the beginning of the situation like this. So now we have data from 5-6 years, after 5-6 years. So I haven't seen any somehow increase in this dilatation. It's pretty much stable. However, I have to say that we are very aggressive with treatment, and we try to have patients in remission as soon as possible. So I totally agree with you that in literature it's an overestimation, and I feel that many of those patients that they have aneurysms and you find aneurysms, they are not so good treated and followed up by the doctors. This is my personal opinion. If you suppress the inflammation, if you really control the inflammation, the giant cell arteritis is in remission, I don't feel that this could be a problem. Of course, some of them they will develop, because if you have an aneurysm in 45 millimeters, this will be bigger and bigger. This is nature. It's a lot of press there. However, I don't feel that GCA is a big problem in this front regarding the aneurysm. That is something that we should consider as a somehow manifestation of GCA so important or so dreadful, like the visual loss.
Thank you, Andreas. Probably it's really like, sorry, Wolfgang, I give you immediately the word, but probably it's really like in spondyloarthritis. So, you know, when you have the bone marrow edema, you need to treat hard at the beginning to get rid of this bone marrow edema. So when you let it go, and then at some point it goes away, the edema, and then it transforms into this fat infiltrates, then you also have a high risk of forming the syndesmophytes. And probably it's a similar course in GCA. So you really need to treat hardly at the beginning, and then you can also prevent this this type of remodeling damage of the arterial wall. That's just a speculation, but I would see some parallels here. Wolfgang, please.
Yeah, I think these dilatations exist. I mean, there's quite something in the literature. So it's probably 2 to 3-fold in the thoracic aorta, probably not more in the abdominal aorta, I think. And I've seen patients, and I've seen people who developed this 10 years later. And this one lady was 85, and she said, "Why should I have a surgery now?" And so some people don't have it. I had one of my last patients who had a surgery when it came up to 55 millimeters. And shortly after surgery, he died from complications of the surgery. So personally, I feel even if we detect dilatations, we will not have all patients, at least who would be operated, or so we probably need to screen a lot of patients in order to have a positive outcome for a few patients. On the other hand, it's worthwhile. It's definitely research agenda, but it's a very interesting point.
So the number needed to scan, that's your term, Wolfgang. The number needed to ultrasound or number needed to a CT would be relatively high to prevent one death from rupture of aortic aneurysm. So I would still have one final question. I still have my patient in front of me. So it's a lady with a polymyalgia and some Wasting syndrome, high inflammatory markers. And now I have the referral to fill it out, and there's one referral for Wolfgang and one for Rima and one for Thorsten. Which ones should I choose? So where should I send my patient to?
Well, the guidelines are, right?
Sorry?
Depends on her insurance. Depends on her insurance.
No, what is really the best, the first test that I should do?
Well, you should read your paper. The first imaging study recommended is ultrasound.
Okay.
And of course,
that's great that you remind me of my paper. I really forgot it. Okay.
Well, it definitely depends. I mean, if you have expertise of MRI in this area, it's fine. If there is expertise in PET-CT and no expertise in ultrasound, it's fine to have the PET-CT, particularly if it's a new one where you even can show temporal arteries. Of course, as we have the expertise with ultrasound, we sometimes send patients where we are desperate, we don't find anything to PET-CT, and everyone's a little bit annoyed because PET-CT is always negative. So it correlates very well if you really look very thoroughly through the patient. So I think several solutions are there. I think it's still very important that we confirm the diagnosis, whatever we are using.
I think that's a good word, and so and probably also the imaging techniques are complementary to each other. So ultrasound has the advantage of being, if you have an immediate access, you can do it immediately in your outpatient office. And when ultrasound is negative and gives you some doubts, and then it probably depends on which one is earlier available and where you have a higher expertise, but probably PET and MRI would work both equally well. I think that's a little bit also the conclusion that I hear from you. And the last comment probably that I would like to emphasize the CT. So not to underestimate the CT. So you know, a lot of patients with fever of unknown region are on the wards, and sooner or later the people will perform a whole body CT, and at least that's my experience, the vasculitis of the aorta and other large arteries are frequently overlooked. So you need really to specifically ask your radiologist, please have a look at the subclavian artery and at the aorta. And they can be evaluated with a normal standard CT scan with contrast agent.
That's totally true, and that will be available anywhere at any time, at least in the hospitals. And you can only measure thickness of the aortic wall, 2.2 millimeters of the axillary artery, 1 millimeter, and you're done. If it's circumferential, it's easy, and you just have to focus on it. Yes.
There is another question in the chat, Thorsten, and this relies whether it is feasible to distinguish between infectious aortitis in contrast to autoimmune related aortitis. Are there typical features in MRI?
Not that I know of. what we can see is the inflammatory reaction of the aortic wall, and we cannot differentiate, let's say, infectious from immune modulated. No, it is impossible, in my opinion. What we can differentiate is the peri-aortic diseases. So if there is, for example, some inflammatory tissue around the aorta, we know, and we can differentiate from lymphoma, which could also be around the aorta, which would press the aorta in front of the vertebral column. So that can be differentiated, but we cannot see the true underlying, let's say, knocks.
Yeah. Thanks a lot.
Same holds true for PET actually. What we also look at, and also can be of additional value, in case of infectious disease, that we also look at lymph node activity. If they are reactive or not on PET, it makes us more suspicious of infection.